Okay, good. I've got about 7:30. Why don't we go ahead and get started here? Who wants to take the first one?
Good morning. Happy Valentine's Day. I'll take this one. Let's see. Looks like we got a deep shave of a neoplastic process within the dermis. Lots of basaloid cells in nests, kind of in that giraffe or jigsaw configuration. As I went down on higher power, it looked like there were kind of two different kind of morphologies of cells. So kind of the cells on the periphery with that darker nuclei, and then kind of these larger cells in the middle that are more pale. Also appreciated kind of this like thickened basement membrane surrounding each of the nests. And so I was favoring that this was a Cylindroma.
Yeah, good. What's this right here?
Like a ductal structure.
Yeah, it's a duct. Yes,
Yeah.
exactly. Good. What kind of differentiation are these things thought to be exhibiting?
So my understanding is like probably like eccrine, but I think there's been, I don't know if that's like confirmed or just suspected.
Yeah, I agree. To me, people argue about this, but when I see these kind of cuboidal cells with limited cytoplasm that are kind of basophilic, like you pointed out there, and then in conjunction with these more clear staining cells, that's really pretty good evidence that it's eccrine. And then if you see the little ductal structures that you pointed out, there's really no apocrine decapitation secretion anywhere. So
Right.
some people say, well, these are all apocrine because you can find one little, decapitation secretion cell maybe somewhere. But I agree with you. I think this is an eccrine lesion. Just a couple of, and this is fairly easy. So this is
Yeah.
kind of might show you on the board. They're going to show pretty characteristic things.
Mhm.
Show you a thing that's like a weird, bizarre, lesion. They might like if they showed you a malignancy of one of these, it would be an obvious cancer. It wouldn't be a benign thing. Now, one thing they might ask you is this thing potentially associated with any heredity situation, any
Right.
syndrome, or anything like that?
So yeah, if there's, multiple, you think Brooks-Spiegler.
Yeah, make sure you know that, and make sure you know the various other manifestations of Brooks-Spiegler syndrome. So could very well ask something like that, because this is a pretty simple lesion.
Right.
The other thing that's often seen in these lesions is there could be multiple. And in the old days, when they really knew about Brooks-Spiegler and the systemic thing, they just would say, well, it can be autosomal dominant, and they just get a lot of them on their scalp, so-called turban tumor. But now we know that you can sometimes get the Brooks-Spiegler situation. And usually if you biopsy those and it's really Brooks-Spiegler, you'll see areas of obvious cylindroma and then areas that kind of look more like a spiroadenoma in the same lesion. Or you may see a more 90% spironoma and a little bit of cylindroma. That kind of suggests that it might be Brooks-Spiegler more than
Mhm.
just regular old cylindroma or spironoma.
Right.
All right, good. Okay, this one's kind of a little interesting one here.
Yeah, this one was tough.
Oh, no, not really. These are like a Valentine's Day present for you guys.
Okay. So
You got a shirt on even, see?
oh, thank you. This one looked like it had a superficial and deep inflammatory infiltrate. And
Okay,
it looked
yeah, it is. It is superficial and deep. Now, the next
like
sort of query is anything about that superficial and deep? It was purely superficial and deep? Is it purely perivascular, or is there anything else sort of about it?
it's like a mixed picture. Like there's some periadnexal inflammation and it looks a little interstitial as well.
Good. That's what I was wanting to get at. Exactly. So in other words, if this was like a lymphocytic infiltrate, for example, like lupus or or a PMLE or one of those things, you wouldn't see this. You'd see mostly just inflammation right around the vessels. You might get a little bit of periadnexal, but it'd be sort of more of a tight infiltrate around the blood vessels. We don't have that here. We've got interstitial as well as around some of the blood vessels. And at this power, what kind of cells are we looking at here?
A lot of them look like lymphocytes.
Some of them may be, but notice how they're not really as jet black and dark as we like to see with lymphocytes, right?
Right.
So we're going to say, no, there's probably some lymphocytes in here, but these, they don't really look jet black. So maybe there's another kind of cell. And that's the main thing I want you to get here. I'm not expecting you to look at this at low power and instantly come up with a diagnosis, but if you sort of see that there's something different when you go to the next power, you'll be looking with a more of a trained eye rather than just kind of, oh, they're probably lymphocytes, you just kind of blow it off. But they're actually, that's important that you'll see when we go to higher magnification. So the couple of clues, it's interstitial and not just perivascular. They're not just purely lymphocytes. What about the epidermal changes?
There are none.
Good. Yes. So what do you think this thing looked like when they presented to the clinic?
So like clinically, like they probably had more like indurated plaques, probably.
Yeah, it could have been an indurated plaque or papule. Would there have been any epidermal change, any scale or anything like that?
No.
No. And then what about the papillary dermis? Is that involved?
No, there's almost like a Gren zone.
Yeah, good. See, these are helpful clues that you can use when you want to kind of arrive at a diagnosis. So you said it was tough, but it's probably getting a little easier now, right? Because we've noticed some things. Well, these aren't all lymphocytes. There's an interstitial, predominantly interstitial infiltration. Go to this power here, it's mostly interstitial. Doesn't involve the epidermis. In fact, there's a Gren zone, if you will. There's all this stuff going on here, and it's not involving the epidermis at all. Okay. And now, as we go to higher magnification, what kind of cells do you think these are?
Are there some like endothelial cells or plasma cells?
That might be a plasma cell here, but do these look like normal inflammatory cells to you?
No.
They don't, do they? One's really got dark hyperchromatic nucleus. It's large. Here's another one that's large and hyperchromatic, and they have relatively abundant cytoplasm, so they're not lymphocytes. Some of them may be plasmacytoid. So these are not lymphocytes. If you do a lymphocyte, you don't see any cytoplasm, basically, right? It's just 99.9% DNA. So here we've got some cytoplasm here. So something's going on here. And these cells are also present in a diffuse interstitial pattern.
Mm-hmm.
Now, we talk about interstitial. I think we may have talked about this a couple of weeks ago. What things do you think about when there's a largely interstitial, mostly pattern? So there is perivascular, but it's mostly interstitial, which is key to this diagnosis.
So there are a few things you can think of, like capices.
Good.
You can think of like interstitial GA.
Good.
I think maybe sweet sometimes, but that's a little bit more dense.
Yeah, sweets less likely, not really sweets, but you're right about some of the neutrophilic dermatoses. The autoinflammatory neutrophilic dermatoses, neutrophilic urticaria itself is mostly interstitial. Cellulitis, so those are things with neutrophils that are mostly interstitial. So yes, you're not sweets, but those other things like that.
And then some like connective tissue diseases, like maybe scleromyxedema.
Good. Yes. Very good. There's still a couple of others. Once we hit the diagnosis, you'll hear the jackpot. The coins will come out of the the little tray like in Las Vegas once you get the correct diagnosis.
Some infections can be interstitial as well.
Which one? We said one a second ago. There aren't too many of those.
Like cellulitis sometimes.
Cellulitis is the main one, yeah. And erysipelas, that sort of thing. but there's a couple others.
Can lymphoma be interstitial also?
Not usually lymphoma. Usually lymphoma is more nodular most of the time. Even when it's secondary in the skin, it usually is more of a nodular pattern. It kind of recapitulates what's going on in the lymph node. But you're in there, but you're getting closer, you're getting warmer.
Maybe leukemia cutis?
Leukemia, yes. And that's what we're looking at here. Leukemia cutis. Okay, so leukemia cutis, what is leukemia cutis actually?
It's just like almost like metastases of leukemia in the skin.
Exactly right. It's a metastatic hematolymphoid neoplasm going to the skin. So what else can give you an interstitial mostly pattern besides leukemia? And the last thing really in our list. So if metastatic hematolymphoid things can give you interstitial mostly pattern, what about other kind of metastatic lesions can give you an interstitial mostly pattern?
Oh, can breast or like
yes, absolutely. Breast carcinoma, that's the one I was thinking of. And rarely melanoma and some other things like that, but metastatic breast, the quote Indian file, the individual cords and strands of cells diffusely, interstitially between them on collagen bundles, that can give you this. So this is leukemia cutis, leukemia. And so these cells here, they kind of look sort of quasi-plasmacytoid. They're really more, and one of the most common ones that goes to the skin is myelomonocytic. So these are probably in the myelomonocytic pathway. I think this was AMML here that spread to this person's skin. So it's a beautiful example of it, and it's a nice example of the interstitial mostly pattern and that differential diagnosis that you work through. That's exactly what you want to think about. This is fair game for the board. Now, they probably wouldn't ask you the type of leukemia, maybe if they said this lesion stained positive for myeloperoxidase or something like that, maybe that's kind of getting closer to dermatopathology boards. But they might show you this with some other information and expect you to recognize that this isn't just a lymphocytic infiltrate, that it's got Grin zone, it's got the interstitial mostly pattern, and it's got these cells that are pleomorphic. So this is leukemia cutis. So that's good. And the most common one of those, that they might ask you that, is really AMML that goes to the skin. All right, great. Very good job. Okay, who wants to give this? So it was hard. You still managed to work through it and made it A, so don't worry. This one is not trash, is a Schnell diagnosing. This is a snap, easy. So one guy gets a toughie, one guy gets an easy one. So we got to figure out some more difficult questions to ask you, since you'll get the diagnosis in about 2 seconds.
I like my path sled like I like my eggs, over easy. So it looks like Angioleiomyoma.
Okay. Tell us why.
The main reason being it looks like it's pretty well subscribed. So we were thinking like a benign neoplastic condition.
Pretty well circumscribed.
Yeah. Pretty well circumscribed.
Much better than this?
No, that is exquisite right there.
Yeah, it's perfectly well circumscribed. And they did a great biopsy. They just kind of punched the entire thing out. It probably felt like a little marble or BB in their skin. Exactly. Okay. Now, why did you arrive at angioleiomyoma then? Tell me how you worked through this.
The main reason being, like, whenever I was looking at the cells, like, it was kind of hard to tell initially what they were, but then a lot of these cells had like a spindled, not necessarily mixoidy, but like a mixoidy kind of appearance to the cytoplasm, and I felt like some of the cells had like that perinuclear clearing, so making me think of it could be.
These are like intracellular vacuoles within the muscle here. It's not really mucin, but there's little clear vacuoles in there. So if you did electron, I wouldn't find mucin in there. And you can see their spindle cell. What's the shape of the spindle cell? This is as high as we can go on this scan image, but what would you call the shape of that?
Would it be like cigar shaped?
Yeah, I agree. I think it's more like a cigar. It's not, swimming like a little fish and say like a fibroblast, like a fibrosarcoma or something like that. It's not that lazy that sine curve that we see with a nerve. Sometimes these can kind of be sort of look a little bit like a nerve, especially when you get them in cross section and you see all these little vacuoles in here. They can kind of look almost like a nerve there. So that's usually in the differential. And you can see this, the cytoplasm, it's kind of eosinophilic here. So all those things favor muscle. And let's see if we can see some, maybe this might be a blood vessel here. It's got some erythrocytes in it. So tell us about the pathophysiology of this lesion.
I think it's whenever the smooth muscle around vessels like veins start becoming bigger and bigger and bigger, and then they form like these well circumscribed kind of appearing lesions.
Yeah, I think that, I'm not sure whether veins or arteries or arterioles. I'm not sure about that, but it definitely it's the muscular wall of the blood vessel that's thought to be hamartomatous here because you get all these vessels in it. Now, if somebody comes in with one of these, they might be painful. You know, these, you know, all the muscle leiomyomas can be painful. So I'm not sure this one necessarily would be as painful as the other types of leiomyomas. If somebody comes with one of these, you're just going to say, adios, we'll see you next month. Don't worry about it. Or do you have to work them up for Reed syndrome if they have this kind of lesion?
I think they just come in with one. I don't know if you have to do Reed syndrome workup or not. I've never seen one in real life, but
No, you're right. You're right. It's really more the regular piloleiomyomas, especially when they get multiple of the lesions, that you have to be more concerned about Reed syndrome. These angioleiomyomas, at least to the best of my knowledge, have not been associated with Reeds like that. It's a different kind of thing. And so the mutation that's associated with Reeds, what's the mutation in Reeds? They could very well ask you this.
it's the fumarate hydrotrace.
Okay, and then if you do, is there any other kind of test you can do like on the patient to look for anything that might be present in a Reed's situation?
I think you get uterine leiomyomas and I think renal cell cancer as well.
And they also get microsatellite instability. So we see that in Muratori. They also can get loss of some, I think, I'm not sure if it's the same thing that Muratori gets, but they can get microsatellite instability in Reeds as well, I believe. So that's something else just to make sure you bone up on. They love asking about syndromes. So make sure you know everything there's to know about syndromes. What's in the differential diagnosis of this? So let's say that we play this game where you're going to be like a sort of a villainous test writer and you want to write some questions that fool your colleagues. What would you put down as a differential diagnosis here that might look like this?
You can maybe put down like fibroma, lipoma, maybe like a globus tumor, schwannoma.
Lipoma would probably be a lousy one. Nobody would choose that, but they would definitely possibly choose schwannoma. You're right about that. You said fibroma. Any specific kind of type of lesion in the fibrohistiocytic differentiation category that can give
Maybe
you a
like
nodular lesion that can, it's more cellular than this, but sometimes they can eventually turn into mostly fibrous tissue.
like a myofibroma?
Oh, that's not a bad idea. Yeah, you can get a myofibroma. Remember we saw one of those, I think, a few months ago or whatever. It's got that kind of very bluish color and is comprised of myofibroblasts. And at the periphery, they get like a myopericytoma vascular proliferation. So yeah, you could toss that in there. What's one
Like
final you might put on there? Especially
a
say
dermatofibroma?
you could, but that'd be pretty easy. But there's one other thing that can look kind of like this and give you a round nodular aggregation, but it's not muscle. You said fibroma. It's in the category of the fibroma-like lesions.
Like a neurofibroma?
No, I don't. I think it would be more like a schwannoma rather than a neurofibroma, this round nodular lesion. What if it's on the volar skin or like say on their hand, a subcutaneous feeling nodule, or maybe it's somebody's foot, or maybe they had a situation where their fingers were getting kind of get into flexor kind of morphology and they couldn't extend them. There's a drug in that.
Like a Dupuytren's contraction,
Dupuytren's
like a
contraction.
fibromatosis.
Yes, good. Fibromatosis. That's what I was getting at. Giant cell tumor of tendon sheath. It can eventually turn into a fibromatosis, Or you can just get Dupuytren's contracture, desmoid fibromatosis, which is associated with Gardner syndrome, plantar fibromatosis. That's the other thing that can give you kind of a nodular type lesion like this. It usually is more fibrotic. Here you can see this is muscle. But if you're going to put some stuff down in the differential diagnosis that you might face on a board examination, those are the kind of things that you might encounter. So they're not going to put lipoma, but they might put some of those things on there. Expect you to be able to tell them apart. It's pretty easy. All right.
Thank you so much.
Thank you. Good job. Let's do this one.
All right, I can do this one.
Good.
So it looks like we have a punch here. We have these hair follicles. It looks like there's a lot of inflammatory infiltrate surrounding the follicles. It looks like there's also some superficial perivascular infiltrate as well.
Okay. What kind of
yeah.
cells are we looking at this time?
These look like predominantly lymphocytes to me.
Good. You're right. And just picture in your mind that last case we had. Can you see the difference in this at low power? They really look a lot different
Mm-hmm.
in those cells, don't they? I mean, they're just little small jet black dots. So yes, I agree. These are lymphocytes. Okay.
Yeah, and then going out, they're like these little look like the hair follicles have like some I guess you can say like spongiosis almost like where these like holes are forming.
Good. Sometimes it's better before jumping immediately to what you think is causing the follicular abnormalities, or whatever. You say, well, it's white. Something's in there, isn't it? It could
Yeah.
be liquid, it could be something else. So we're going to look at that. So this is abnormal. Right off the bat, you say this is absolutely positively not a normal finding. And yes, it certainly could be spongiosis, but it's not guaranteed to be spongiosis.
Mm-hmm.
So let's go to higher magnification. And let's see what we think this stuff is. Some of it very well may be, but can you see that some of it's kind of got a slightly granular
Yeah,
sort of
looks like there's
color?
some mucin there.
Yes, there's mucin.
Yeah, so I thought this was like follicular mucinosis.
Okay, so tell us, what is follicular mucinosis?
So you get these like pools of mucin around like the hair follicles.
Well, it's in the hair follicle, isn't it? It's actually
Yeah.
inside the follicle. So what is it itself? I mean, that is actually what's happening. There's mucin within the follicle. But what do we call that sort of finding histologically when we see that as a general rule? Like we see, for example, if we saw spongiotic dermatitis, that's one. Here's a little bit of spongiosis up here. If we saw acantholysis, here we're seeing follicular mucinosis. So what do we call that?
I'm not sure.
Yeah, well, you know the answer. I'm just asking it in a funny way, but basically we call it a reaction pattern. It's one of the ways that the skin can react to certain things. So something is causing the follicular mucinosis. It can be, how can you get follicular mucinosis? Tell us how this happens. There's really only about 2 or 3 ways that it can happen.
I know sometimes it's associated with like mycosis fungoides.
Good. And that's the thing you have to exclude, right? You don't want to miss that. What's another way it can happen? There's really only a few ways it can happen. It's kind of an interesting phenomenon because it only happens about really just 2 or 3 or 4 ways, not a ton.
That's like the main one I know. I'm not sure if there's like any infections that can cause it.
Not usually, but that's a good idea. What about if it was just there saying maybe a 5-year-old kid? Or you say, oh my gosh, the kid's got MF?
No, I think usually it's older people where it's associated with MF, typically younger.
What if it happens? What if you see this in a young kid that comes in with a big boggy plaque on their cheek and you think it might be an infectious disease, you take a biopsy and it shows this. Are you going to work them up for MF?
No, I would think it's more benign.
Yes, good. So there's a benign, idiopathic, solitary variant of this. And that's what we just call alopecia mucinosa. And it's usually actually often seen on the scalp where they lose their hair and you biopsy, you think they might have alopecia areata or something else. And lo and behold, it turns out to be this. and that's the benign variant. And there's one other setting where you can see it, and this is one you probably don't know about as much, but sometimes you just see it as a coincidental reaction pattern. You see somebody that's got rosacea, or maybe they've got, some other inflammatory skin disease, and lo and behold, they got a lot of mucin in their follicle, and it's just not MF, and it's not alopecia mucinosa because they don't have the boggy plaques or anything. It just can be a reaction pattern. That's relatively rare, but we do see that on occasion. So that's good. Now, you said that you thought this was spongiosis at low power, and sometimes it can be kind of tough to tell that apart. When you get this massive quantity like this, and you can see this kind of bluish gray material, that's more likely to be mucin. But what if you wanted to distinguish those between spongiotic dermatitis and follicular mucinosis? Is there anything you could do to kind of help you distinguish between those two?
Yeah, you can do a stain. It's either like Alcian blue or colloidal iron.
Good. And those would be positive as a general rule, but tell me the difference between mucin that lives out here that's produced by these cells and mucin that's produced by these cells. These are being produced by keratinocytes, interestingly enough.
Yeah, I think the keratinocytes produce like a different type of mucin. The mucin that's produced here in follicular mucinosis is like the mucopolysaccharide.
Well, they're both mucopolysaccharide, but this is a different mucin. It's like a sialomucin, and that's epithelial mucin. It's more analogous to the kind of mucin that you get in, that you're produced by glands, like salivary glands, or mucus glands, like in your nose, those kind of things, or respiratory tract. So that's more of an epithelial mucin. It's a more acidic mucin. It's got a lower pH than hyaluronic acid that lives out here. They're both kind of similar chemical products, but they're a little bit different. They used to ask that question on the boards years ago when Jim Graham was on the board, and he loved that question. But this is a beautiful example of follicular mucinosis. And if you see this, you're obligated to make sure the patient doesn't have MF. Usually if they have MF, you kind of look up here and you see features of MF up here. I don't really see that here. There's no epidermotropism. There's no atypical cells. There's really no sun-damaged skin. So this probably was just an isolated coincidental alopecia mucinosa, probably in a young individual. But it's a great example of it. And they might show you this because it's important to know everything that you just said. Okay, let's take a look at this one.
I'll give it a try.
Okay, good.
We have a punch, and I think it's neoplastic, though from a distance it could maybe trick you to being inflammatory.
Okay.
And then the epidermis strikes me as pigmented, the basal layer, and I saw some smooth muscle in there.
Okay, so let's step back a second. So you said neoplastic. You think it's epithelial or non-epithelial?
I think, can it be both?
Okay, good. So you know the answer, so you're having to work backwards, obviously, if you got it. So yeah, so is this really a neoplasm?
Well, I don't know that it fits nicely into either, but if I had to pick one or the other, I'd pick neoplasm.
Yeah, that's really, we sort of try to put the world into inflammatory neoplastic, but there's actually other categories too that are sort of asterisk categories. Deposits, are those really inflammatory neoplastic? If somebody got deposits of amyloid in their skin or whatever, probably not really. Hamartomas, are those really neoplasms? No, not really. They're kind of like birth defects, if you will. So they're sort of genetic abnormalities. So you kind of always have to say, well, it's closer to a neoplasm than an inflammatory process. So yes, you're right. This has two things going on. It's really got three things. We'll talk about that in a minute too. So what's the diagnosis?
I thought it was a Becker's nevus with
Okay.
the pigment and the smooth muscle. I also thought about the smooth muscle hamartoma as well, though.
Okay, well, actually, the Becker's nevus smooth muscle component, a lot of people say is a smooth muscle hamartoma. That's kind of a component of the Becker's nevus. So you can sometimes see Becker's nevus. If you did a shave here, you wouldn't have even found this, right?
Right.
This deep this time. Actually, most of the time when you see these Becker's nevi, the muscle is way the heck up here. Now, when you just look at this at low power, so you figured it out and then you sort of went back, but let's go back and pretend like you've never seen the slide before and ask you what part of the body you're on. What would you say here?
I would say trunk.
Yeah, it doesn't look like there are very many follicles here. Okay, so if you want to make the diagnosis of Becker's nevus cold on an exam, not where you have a chance to look at a textbook and spend time and discuss and all that kind of stuff, you should notice that there's no follicles here, but there's lots of smooth muscle. That doesn't make sense, does it? Because normally these are associated with hair follicles. So if you see this, lots of smooth muscle, acanthosis, hyperpigmentation, you say, wow, this should make you just instantly, bells should go off, possibly Becker's nevus. And yeah, and they wouldn't say, which is the right answer, Becker's nevus versus smooth muscle hematoma. That would be very, very tricky. That to me would be borderline unfair, because this is a smooth muscle hematoma. Now, the best answer would be Becker's nevus because it's got both. And if you just had only a smooth muscle hematoma, you probably wouldn't see these changes up here. But that's not a good question. So I don't think they would ask that. But just notice that there's no follicles and there's lots of smooth muscle. So that's abnormal right off the bat, just like the last case. And you see, something's going on with those follicles, low magnification. That's abnormal. Now, what's this? So they might try to trick you also on the exam. They might put on their dermatofibroma. Why would they put dermatofibroma on there as a possible choice?
Because you can get the fibrohistiocytic change that has pigment, or was it hemosiderin deposition?
That's one possibility, but there's another answer in the epidermis. So if you look at the surface of a DF, we get a lot of shaved biopsies of DFs. They shouldn't shave them because you really hardly ever get into the lesion with a shaved biopsy. But there's something you can see on the epidermis overlying a DF.
It's more flat.
Well, you can get acanthosis. So the next time you look at a biopsy of a dermatofibroma, notice that you can get hyperpigmentation of the epidermis and acanthosis, and sometimes you get a basaloid proliferation that can simulate a superficial basal cell carcinoma. In some rare cases, you can even see sebaceous proliferation overlying a DF. So that they might throw that on there, and you might say, yeah, it's got the epidermal change of DF, and yeah, there's some thick collagen bundles here, and there's some dilated blood vessels, and there's some pigment of some sort here. Maybe it is a dermatofibroma, but you'd lose because you have this, right? So we wouldn't fall down that pit. What's going on here? What is this material?
The dark stuff, is that what you're talking about?
Yeah. What if they
thought it was just
blue
pigment
nevus on?
incontinence.
Would you go after blue nevus here?
No, I'm not impressed enough by that.
Good. Very good. You're hard. You're not going to let them fool you. I like that. That's great. No, these are not the cells of a blue nevus. These are large clumps of melanin, and there's pigment incontinence. And so why the pigment incontinence? Well, there's a lot of epidermal hyperpigmentation, so maybe they got a little bit of inflammation or irritation, and you got a secondary, irritant dermatitis, and they got some secondary post-inflammatory pigmentary change. So yeah, that's not a blue nevus. So this is not hemosiderin either, right? How can you tell the difference between hemosiderin and melanin just looking at H&E? This is one of the things that's bad about digital stuff, by the way, just so you know.
I'm actually not sure. I'm not good at that.
Well, hemosiderin is a crystal, right? It's iron. Okay. And so if you actually have your microscope, you can actually rack down the condenser a little bit, and you can move the objective up and down, and you can actually see it kind of is refractile. The light is refractile through it. Melanin is not refractile. It's not a crystal. It's a molecule, long-chain molecule with, all sorts of amino acids and things like that in there. And it doesn't, you can't get light that actually passes through melanin like that. It's jet black. So you can tell the difference between hemosiderin, which is kind of a golden brown, versus melanin, which is dark brown to black. Okay, so you can tell it apart. So that's not hemosiderin, even though there's some dilated blood vessels here. So this is a Becker's nevus. Do we have to worry about any syndromes with Becker's nevi?
There's one like a phacomatous, I think, that has it. That's the only thing I can think of.
Yeah, and I'm not aware of too many things that are associated with it. There are other kind of lentigines that you can see with syndromes like Lozier-Hunziker syndrome and Carney's. You can get lentigines, things like that. So make sure you know those. And yeah, I know the phacomatoses. That generally will tend to give you this kind of reticulated epidermal hyperpigmentation and a hyperplasia like that. You know, golly disease, Dowling-Dago. So make sure you know those before the board examination. All right.
Okay, I can take this one. So
Okay.
this looks like a deep punch to me.
Right.
They went down to the subcute. So usually when I see a deep punch, I become biased. I go straight to see if they are looking for facial or if there's a pathology of the subcutaneous fat. So what caught my eyes is that there's a lot of inflammatory changes around the fat cells. It's more of a lobular pattern of paniculitis, and it's more of a granulomatous inflammatory changes. At
The
low
overall
power.
is it only a paniculitis?
Yes, so so once discovered that this is more like a lobular paniculitis, the next thing I was looking for if there's an associated vasculitis. And
Yeah,
I
that's
felt
good. I agree. That's exactly what you want to do. But notice, do you think it's only in the paniculus here? Do you think it's purely a paniculitis?
so I think there was also some granulomatous changes in the mid dermis also.
Well,
They
there's
look,
definitely also some dermal inflammation.
yeah,
Yes, it's dermal. So you got this kind of almost nodular inflammation in the surface. It does go relatively deep. There
yeah,
is some granulomatous inflammation in here.
yes,
And then there is involvement of the fat down here, as you've noticed. So it's kind of a
yes,
dense, diffuse infiltrate
yeah,
with uh, with involvement of the fat also.
yes. Then I thought I saw some vasculitic changes. There was some inflammation in a blood vessel, down in the deep dermis and fat.
You're talking
I
about these areas.
Yes,
Okay.
yes.
Was there any
So
thrombosis of those blood vessels?
yes, yeah, thrombosis, and I also saw some thrombosed blood vessels in the site. S-
Let's take a look at that. So I wasn't sure I saw any real true thrombosis. Now there's some sludging of erythrocytes in here. I'll agree with that. But I didn't see any real true vascular thrombosis. So you can get, the point is that you can get, if a relatively large blood vessel has got inflammation within its wall, you're right.
yeah,
It's evidence of vasculitis, but it can be secondary vasculitis. So you get primary vasculitis, like immune complex mediated vasculitis, vasculopathy, or you can get, if you get inflammation in a large blood vessel, it's not, it shouldn't be there. And it could be primary or secondary. It's possible. What are some of these
okay.
cells?
So I thought I saw some histiocytes, lymphocytes, and maybe some plasma cells.
What about this cell? And
Uh,
unfortunately, we can't do a higher
this
magnification.
looks like this look like eosinophils.
Good. Very good. Excellent. So this is a mixed infiltrate.
Yeah.
Diffuse, nodular, mixed, histiocytes, lymphocytes, some plasma cells, some eosinophils. Starts off at the top, it goes all the way to the bottom. Okay, so
Yeah.
that's our pattern. There's secondary vasculitis. It's not
Second.
leukocytoplastic, right? We don't see any LCD or anything like that up here, right?
No.
Okay, good. So what gives you something like this?
So the only condition that I know that cause both like lobular panicolitis and secondary vasculitis is nodular vasculitis. That
Well,
is
what do we usually see inside the lobules of nodular vasculitis? What usually happens to the fat in nodular vasculitis?
you also have fat necrosis.
You do have fat necrosis. Good. You get
Yes.
degeneration of the fat, and you also get suppuration and granulomatous inflammation in the
Yeah.
lobule.
Yes.
Here, we really don't have neutrophils, right? We've got mostly lymphocytes and eosinophils here.
Yeah.
So with EOs, what do we think about?
You can also have eosinophilic fasciitis, but this I didn't really see inflammation in the facial. It didn't
Good.
get down to the facial.
I agree. I don't think that's what we're looking at here. I think we've got a dermal inflammatory response that goes down into the fat. And you're right. So you can think of eosinophilic fasciitis. What else do you think about just in general when you have eosinophils in a biopsy?
You can have like I think about BP.
You could
bullous
think of
pemphigoid.
bullous pemphigoid. Yeah, that usually gives you like a band-like infiltrative lymphocytes and eosinophils.
Yeah.
What's another thing you think about when you've got eosinophils here?
You can think about arthropod.
Yes.
So
Yes, like a hypersensitivity reaction, like an arthropod assault reaction,
Yeah.
something like that.
Yeah.
So when we see EOs, maybe we're saying, well, yeah, it looks like it might be a paniculitis. There is paniculitis. I totally
Yeah.
agree. When we see the eosinophils, you say, well, there's also this granulomatous inflammation. There are these lymphocytes and eosinophils up here. It's kind of a diffuse process.
Yeah.
Is
Look, I
it
think
possible this is some kind of a weird hypersensitivity reaction?
hypersensitivity. I know I consider the possibility of stress as he he eosinophilic granulomatosis and polyangiitis. GPA.
You could see that, but that's usually going to give you that gives you more of like almost analogous to a leukocytoclastic vasculitis involving the blood vessels, and it can give you. I mean, it does have some granulomas. So you're right. That's something you should think about here. But the pattern of that is generally somewhat different. But this is a hard case here. I'll just tell you that this isn't an easy one. So your differential is correct. I think those are some things you should think about. This is just a reactive super over florid manifestation of like an arthropod assault reaction.
Arthropod assault.
So that's the diagnosis in this case. Now, the other thing I'm going to ask you about this is where do you see this kind of change? Because it is unusual. This isn't just a regular garden variety bug bite reaction, is it? This is going down into the fat. It's got some granulomatous inflammation. Where do you see this pattern?
It can be like due to a reaction to parasites, like a parasitic.
Well, let's say it's a bug bite, what kind of patient gives you this kind of massive inflammatory reaction that gives you a paniculitis?
Like patients that immunocompromised.
Very good. That's the answer. Yes. And that's something that you might encounter on the board examination. They might ask you that. That's fairly hot topic recently. Dr. Hyman wrote a nice editorial about that in the JAD about a couple of years ago or so. And it's kind of an interesting thing. A lot of these patients don't have massive immunocompromise. Some of them may have an underlying B-cell lymphoma or some kind of mild immunocompromise. And they get bitten and they get these horrible, massive arthropods bite reactions. And the other thing that they will do is sometimes they get one bite and they get a recall reaction where they may have had bites, 15, 20 years ago. And we used to see a lot of these with the HIV positive population. They'd come in and, maybe get a bug bite and then suddenly they pop up with 100 lesions on their body because they have this altered Th1, Th2 response and they get these unusual reactions to bug bites. So you probably wouldn't just get that off the top of but something to at least consider when you see this kind of reaction. And this may just be related to rupture of a follicle. It could have maybe been it could have been a tick bite. Tick bites
Okay.
will often give you a very florid pseudolymphomatous reaction like this also.
Thank you.
All right, very good. Okay, so this one, kind of another relatively easy one.
Good morning. Can you hear me?
Yes, absolutely.
Thank you. This is a shave biopsy of like a little papular nodule, exophytic type of lesion, and it's very blue. There appears to be tons of acanthosis,
Good.
and they're kind of ropes of acanthosis going down and connecting to one another. And then there's these like openings in between, and they're filled with some material.
Okay, good.
It appears very
We go weak.
symmetric.
Good, good.
You're right. It's kind of like symmetric. Doesn't it doesn't appear to be too infiltrated, so I favored a benign neoplasm at this
You're
power.
absolutely correct, for sure. And this looks like it's sort of it's like a little sessile papule. They said, let's just shave this thing off, and it goes from here to here and here to here, and it's very symmetrical. I totally agree. It's benign. And you said it's epithelial, so absolutely. So the next step is obviously what type of epithelium we're dealing with.
So I think my differential included things like keratinocytes, like SKs or SCC, but then going closer, the cells look a little bit different, like similar to one another,
Good.
but a little bit more round, perhaps, and then with the little spaces in between, I wondered whether it could have been adnexal instead, like a glandular type of epithelium.
Yes. Good. Excellent. Very good. That's exactly what it is. And here, what have we got?
These are more of the, would you call them more cuboidal cells?
Well, there are cuboidal, I agree. But what am I circling right there? What is
Oh.
this structure?
Oh, let me pull in closer. Oh, a little duct.
Yeah, good. So that's helpful. Just like we had the Cylindroma previously that had the ducts, you got some
Right.
ducts here also. So that helps you when you're dealing with a potential adnexal neoplasm. Good. So I agree. This is in the adnexal category. What type of differentiation are we looking at here?
I thought it was Eccrine.
Right. Good. So what's the diagnosis?
An Eccrine Poroma.
Eccrine Poroma. Excellent.
Eccrine.
Now,
Yes.
there are 4 scenarios where you can see these type of cells. And we actually call these, because they're so monomorphous and so cuboidal, and they really look so clonal like this, we actually call it poroid differentiation. Because it looks like, when we saw poroid, means the cells of the poroma. So there's 4 lesions where you can get poroid differentiation like this. Really 5, but 4 benign lesions.
Okay. Let's see.
The board will not ask you to do this, but if you can do this, you're like you're ahead of your non-taught colleagues regarding this. So poroma is 1, so we have 1 we know.
Oh boy. Okay, we have
What are the
1,
others?
and then I believe if it's more at the epidermal level, looks more like a clonal SK, then would that be hydroacanthoma simplex?
Would be, yes. What's the next one?
If it's only in the dermis, then it's a dermal duct tumor.
Perfect. And we have 1 more to go.
And the poroid hydroadenoma.
Yeah, poroid hidradenoma. Good. That's where it's in a dermal-based nodule, and you get the poroid cells there. The last one is a porocarcinoma, which actually is one that's malignant. But the 4 benign ones you've got. That's exactly right. So just make sure you know those. Now, there's one thing here that's not in this lesion that is histologic. It's sort of almost it doesn't match. In other words, it's something that you shouldn't see
Okay.
in a benign lesion, but we do see it often in these poroid lesions. What is that phenomenon that I'm talking about? It's not here.
It isn't.
Maybe it's a little bit. Maybe it's there a little bit.
I don't. I felt like I was reading they could have some clear cell changes sometimes, but I don't think that's where you're.
But there's a phenomenon that we see sometimes in poroid lesions that's usually seen in a malignancy, but it's
Oh,
actually not malignant in the poroid lesions. It's very common.
oh boy. I'm not entirely sure.
That's okay that you're not sure. That's perfectly fine. We see necrosis en masse, areas of necrosis of cells in poroid lesions. Usually that's seen in malignancies. So if you see a melanocytic lesion that's got necrosis en masse, boy, that's melanoma until proven otherwise. I mean, you get super worried about that. If you see like an epithelial neoplasm that's squamous and it's got necrosis en masse, wow, that's probably squamous cell. But if you see a poroma or a poroid hidradenoma that's got a little zone of geographic necrosis in there, you don't say that's porocarcinoma or hidradenocarcinoma. You just sort of say, we know that can be seen in these poroid lesions. It's not seen here, but that's just another thing to know about because you do see that not uncommonly.
Excellent. Thank you.
Very good. Good job. Okay, let's do this one.
Okay, I can do this one.
Good.
So from this one, I saw a punch biopsy, and it looks like most of the action is kind of in the superficial dermis and the epidermis.
Okay.
And it looked like from this power, there are some kind of like nodular aggregates of darker cells in the dermis.
Good.
So I was thinking those were probably going to be lymphocytes.
You're probably absolutely correct.
And then I kind of zoomed in, and at first in the epidermis, I thought that it was like vacuolar changes. But then when I looked at it a little bit harder, I felt like it was more of a like epidermotropism and pagetoid spread.
Good. Okay, so pagetoid involvement of the epidermis. Good. Excellent.
So I was kind of going down the differential of things that can have pagetoid spread and looking more closely at the cells that were doing the spreading. And I felt like they were mostly lymphocytes, some like atypical looking lymphocytes.
Okay. Is that a lymphocyte there though?
I feel like that one has more cytoplasm than a lymphocyte would have.
Yeah, it does. Okay, but you're right on track. Okay, so this is exactly what you should be observing here, precisely. Now, this stuff down here is kind of a fooler because this is reactive inflammatory process to this.
Okay.
This doesn't belong here. So these guys are saying, hey, wait a minute, there's cancer here. We got to come and try to attack it. So that's basically what's happening down here. These are tumor infiltrating lymphocytes, if you will.
Okay. So
we have to ask ourselves what's going on up here. And yes, one thing is lymphoid infiltration into the epidermis. Now, I think if the board gave you one, they probably would maybe give you some additional information. You can see that this has got more cytoplasm than a classic lymphocyte. But you look at a couple of these, it just looks like it could be a lymphocyte right here, for example. So I don't know that they would throw mycosis fungoides and then other pagetoid things in there unless they had some other information for you to do this. If they wanted to just have you do it on H&E alone, that's kind of more of a dermatopathology board question. But what are items in the differential diagnosis here that you have to think about?
So then you could think about like they're melanocytes and you have a melanoma.
Excellent. Very good.
Other pagetoid things, obviously you can think of Pagets, but usually they're more pale cells and kind of more bluish.
Just so you know, this actually turned out to be Pagets.
Oh.
So and it shows you these can kind of look sort of, they can be tough.
Yeah.
So that's why I don't think they would just ask you, is this Pagets versus melanoma in situ? But they would ask you possibly somewhere the differential diagnosis of these things. So you do need to know the other entities that can give you pagetoid intraepidermal involvement. So you said a few. What else can give you this pattern?
You could see it in like Bowen's or SCC can do Pagets.
Yes, very good. What's bad about that for this though?
Like there's no atypical keratinocytes.
Yeah,
really.
usually you usually get full thickness atypia. It's a classic squamous carcinoma in situ, just with some pagetoid cells in it. So that would probably not be the world's best selection. But you're right, you definitely can see pagetoid Bowens. What else? Just a couple other things.
I think that's like Langerhans cell histiocytosis.
Very good. Yes, absolutely. Yes. You're getting close to the end.
I'm not sure if Merkel can do Pagetoid.
You're absolutely right. Merkel can do it. Yes, it certainly can. You're right. There's one more.
I think the only other one that I think is sebaceous carcinoma.
Thinking right. That's exactly right. Those are the main ones. There may be a couple of others, but those are 99% of the ones. So those are the ones you need to know. And then obviously they might show you this and say this highlighted positively with cytokeratin 7. What's the most likely diagnosis? You know, they might show you a CK7 picture adjacent to this. This might be like a Cockerell kind of question. So then you know it's Paget's disease and not the other. And then obviously if they have Paget's disease, there's two types, right? There's
like Paget's of the breast and not elsewhere.
And then there's extramammary Paget's. And then the extramammary Paget's can be associated with either an underlying GI or GU carcinoma, or you get the, it could just be just a solitary lesion that is not associated with underlying cancer. So you have to work them up for the cancer. All right, I got time for one more quickie, if this thing loads properly, which it's not. Weird. Well, maybe we don't have time for one more quickie. Anybody remember what the last diagnosis was? Here it is.
I can do this one. Can you hear me?
Yep, hear you perfectly well.
All right, so here's a shave, and you kind of already zoomed in on the spot I was gonna highlight. On the left-hand side of that shave, there's lots of acanthosis, dyskeratosis. You can see kind of that like villi-looking nature of the basal layer.
What's the reaction pattern? What's the reaction pattern?
The reaction pattern, I would say it's epidermal acanthosis.
Okay, but what's the name of the reaction pattern? You're there. Just put a name on it.
Acantholytic dyskeratosis.
Very good. And it's focal. Focal.
Focal.
Right. It's not diffuse. Focal acantholytic dyskeratosis. Where do you see that? Which diseases?
You see it in Derrier's disease. You can see it in Grover's disease.
Good.
Haley can sometimes look like that.
Good. Of course, it's not really focal in Haley, right?
Right. And then I know there's like that rare like familial dyskeratotic comedones, but I don't think it's that either.
Good. And then you also can get it in, linear Derrier's, too. So that's good. Okay, that's the different. You got it. That's the answer. Now, they're going to put on the exam herpes. Are you going to fall for that?
I don't think so, because I think they're more corpse rons and grains than
you got
poilocytes.
Grains here. You get that in herpes. You don't get that in herpes, right? You get that in this.
Right.
There's no viral cytopathic effect here. That's the key. These are just acantholytic dyskeratotic cells. There's no viral cytopathic effect. They're going to put pemphigus. You can choose that? Pemphigus vulgaris? Nope. Good. You're not going to choose superficial pemphigus either, right?
Right.
Good. Good. Well, you guys are getting confident. I like it. You're not going to let anybody talk you out of your answer. That's key. All right. Good job, everybody. And we will see you guys next month. We're gonna have a ski meeting next year. So if anybody that likes to ski, we want you to come to our meeting next year. All right. Good job, everyone. See you next month.